Good morning, everybody. Good to see you. It's a small little group today, and that works all right. I know a lot of people here, a lot of friendly faces. So yeah. My name is Teresa Hicks. I work for the ANTHC diabetes program, and I am here today to talk about including diabetes distress in the diabetes conversation. I think that might look a little different than what you have on your agenda. Same topic. I couldn't remember what I called it initially. I think I've changed the title, but it's the same topic. Okay. With just a little bit of audience participation, go ahead and raise your hand if you have felt some real stress in the last month. Oh yeah, see, that was easy. That was very easy. Okay, kids, jobs, whatever, some real, maybe the reauthorization or not of the STPI diabetes grant. Yeah, some real stress in the last month. So I want you to think of one way that your body responds to stress. So for example, when I'm really stressed, I cannot sleep. So yell it out, no wrong answer, yell it out. What's one way your body responds when you are really stressed?
Nail biting.
Nail biting. Headaches. Muscle tension. Yes. Increased eating. What was that over there? I heard something. Yell it out. No wrong answer. More tired. Yeah. Insomnia. Yes. My personal favorite. Yes. Cranky. Yes. Yes. Okay. So stress, there is no system in the body that stress does not affect. Respiratory, cardiovascular, endocrine, musculoskeletal, reproductive, GI, you name it. It affects every system of the human body. And with a disease like diabetes, a head to toe disease, it makes sense that we would want to pay attention to anything that affects every system of the human body. So stress, of course, can be protective, right? It can be helpful, just like pain. We don't love it, but it has a role. It protects us. It keeps us safe. We've heard I'm in a dark alley, something comes behind us, our adrenaline goes up, norepinephrine, our cortisol, blood sugar, blood pressure, it gets us to safety, right? That is acute stress. The stressor is gone and we return to our pre-stress state. But I'm not here today to talk about helpful stress, as you might have guessed. I'm here to talk today about, my slides are not advancing. I don't know where the guy is, so I cannot see on my screen. Anyway, stress. I'm going to talk a little bit about stress, and then we are going to move more into diabetes distress, specific distress. We're going to talk about how stress and diabetes distress affect our body and our behaviors. And we are going to talk about tools for addressing healthy coping and reducing diabetes distress. What is stress? How would you define that? We say it all the time, but it's like a weird word, like, right? What's the definition of that?
Alarm clock.
An alarm clock? Okay. You want to elaborate on that? Or stress, the alarm clock itself is stressful? Okay, all right. Anyone? How would you define stress? Yeah, that's good. That's good. Yeah. So stress is really our body's response to any situation or any condition that throws us off balance. We like to be in homeostasis, right? Our body likes to be in homeostasis. Anything that pushes us one way or the other is stress. And anything that pushes us is called a stressor. We have good stressors, babies, new jobs. We have bad stressors, car wrecks, losing a job. And we have my personal favorite, perceived stressors, things that aren't actually real, that don't actually happen, but just in case we stress over them anyway. I have a visual that I like to use to describe frequent or intense or chronic stress, and it is known as the wheel of stress. So if I have an outside stressor and I respond to it with stress thoughts, I can't see my slides actually, if you could like match it, thank you. And I'll talk loudly over here. Okay, let's been there. And there we are. Okay, thank you. Okay, so the wheel of stress is used to, it's a visual for looking at frequent, intense, or chronic stress. So if we have a stressor coming in and we respond to that stressor with stress thoughts, things like obsessive thinking when we perseverate on something, or negative self-talk, or telling ourselves a story, then we have those effects on our bodies, those things we just yelled out, right? Any of those effects that stress has on us, that's a response to our stress thoughts. And the more intense and more frequent our stress thoughts are, our body responds to those. And eventually, our body is going to figure out a way to cope. If we respond with stress coping, we might do something like scream and yell, be mean to someone who doesn't deserve it, slam a door. We might isolate ourselves, cut ourselves off from people that are important to us. We might use alcohol or tobacco, but we cope in a way that isn't productive, which of course leads us to shame and feeling bad. And we know we shouldn't have done that. And the stress thoughts, which again turn to stress body. And the wheel spins around and around until some of those health effects we mentioned earlier start to become health conditions. So we're going to talk about how to stop the spinning wheel of stress. And we do that by breaking the cycle by using, instead of stress coping, healthy coping. Healthy coping practices activate the relaxation response. So the relaxation response was first identified in the 70s. And I love this because it's defined as a state parasympathetic dominance. Like, I want a t-shirt that says that, right? Like parasympathetic dominance. That sounds so awesome. So that's the relaxation response. We have the autonomic nervous system with two branches, right? That first one, that sympathetic nervous system, that's the dark alley. That's all those, epinephrine and cortisol and blood sugar and all that stuff. And the opposite of that is our parasympathetic nervous system, which is the brakes. It's a cascade of chemical reactions that stops the stress response, or really slows the stress response. So we don't want a car with no gas, but we really don't want a car with no brakes. If we practice using healthy coping, we can put the brakes on that spinning wheel, even if none of the stressors remove themselves. Even if we stay in a state, if there's chaos all around us, we can still force the relaxation response. I'm going to tell you how. Okay. Coping skill number 1, how to stop the spinning wheel of stress. So I'm giving you a sports analogy. And it's important to know that I don't actually care about sports. Unless someone I gave birth to is playing, I don't ever really want to watch them. But sometimes the people I gave birth to think that a really great vacation is watching professional sports somewhere. Okay, so I've been there, I've been to professional games. And here's something you can see at a professional game. LeBron James on the free throw line, right? His job is to get the ball through the hoop. And I don't know how many people are there, but I'm going to say like 30,000 people, give or take 10,000. I don't know. But a good half of them are screaming really negative things at the guy on the free throw line, right? Thank you. Really negative. They are really not wanting him to make that basket. So they're, I don't know, you suck, miss. I don't know what they yell. They're yelling all kinds. I don't care. But a lot of people care. And they're yelling this. But LeBron has to figure out how to calm himself in that sea of chaos and get the ball to the basket. So he trains himself, right? Just like he trains his body or his skills, he trains his mind. Here's what he does, which you can watch it on the TV if you're a person who watches professional sports. He does, right? You see him. Why? Because it works. Healthy coping, number 2, breathing exercises work. They elicit the relaxation response. It's facts. It works. It's not just hippy dippy. It really does work. This is a particular breathing pattern that's good for anxiety. Inhale for 4 seconds, hold for 7, and then a really long exhale. There's other ones you can do. I don't know what they are, but I know this one. And this is the one I teach, and this is the one I do. And so we are going to do this one tool together. Okay, not as much as I'd like to. I'd like to have you do it 3 times, but for the sake of time, I've timed myself. We don't have time for 3 rounds. We're going to do 2 rounds, but I'm going to count. Then you can tell me if you're in a state of parasympathetic dominance when we're done. Okay, all right. So I'm going to count for you. I'm going to count to 4. Then we're going to count to 7 for you to hold. And then we're going to exhale for 8. We'll do it once, and don't feel bad if you messed it up on the first time, because then we're going to do it a second time. All right? First one's for practice. Go ahead and make yourself comfortable. You can put your hands to your side. You can put them on your lap. If you want to close your eyes, if that makes you feel comfortable, go ahead and close your eyes. Okay, so go ahead. Inhale through your nose, 2, 3, 4. Hold, 2, 3, 4, 5, 6, 7. Exhale through your mouth, 3, 4, 5, 6, 7, 8. Okay, we're going to do it one more time, just in case you didn't quite get it that first time. Here we go. We're going to go inhale through your nose, 2, 3, 4. Hold, 2, 3, 4, 5, 6, 7. Exhale, 2, 3, 4, 5, 6, 7, 8. Okay, how do you feel? Anyone feel that? Yeah, all right, I got some heads. I should have stressed you out first so we had a better dip. Okay. In diabetes education, we teach tools, right? We teach how to use blood glucose monitors, how to use CGMs, injectables, carbohydrate counting. We have all kinds of tools that we teach people how to use. We don't ever say, here's your monitor. There's a YouTube video on that. Go check it out, right? We don't say that. We open the box up, we take it out, we have folks practice it, they try it on themselves, we do it. And we do that because we follow, in diabetes education, the principles of adult learning. We know that adults learn best when they do things hands-on and when they're able to practice skills in a safe environment. We know that stress affects our body head to toe. There's no system left out. I really haven't heard of people practicing these kind of skills before. I often have heard, have you ever heard of guided visualization? There's some great YouTube videos on that. You should check this guy out. People are nodding their heads. Yes, right? I've had that happen to me at healthcare appointments too. Oh yeah, you've got stress? Here, go check it. You should Google this guy. Yeah, okay. So I'm going to talk about tools that we can do in a one-on-one clinical setting as well as group education. Okay, as far as comparing coping tools, healthy coping tools, along with deep breathing, there's progressive muscle relaxation, which I have taught as well. Some people in here probably heard me do that before. Guided imagery, these are things you can do together with folks. One works in studies, works as good as the other. Some people have preferences. Some people like to combine tools, but they all work to elicit the relaxation response. Other healthy coping tools, physical activity, produces the relaxation hormone oxytocin, taking a walk. There's cultural practices, not of course research, probably based on things like berry picking and feeding, but we know that they are helpful for many people as healthy coping tools as well. But let's talk more specifically about diabetes, because diabetes makes things harder. I want you to meet Joe. Joe has type 2 diabetes for 15 years. He's 58 years old. He has a BMI of 27. He lives alone. He's got an A1C of 11, some beginning problems with neuropathy, takes oral meds, insulin, and he uses a blood glucose monitor. Okay. So Joe comes into clinic, and this is what Joe has to say. He doesn't check his blood sugar because the batteries are dead, right? He doesn't have any blood sugar with him. He didn't bring his monitor with him today, but he hasn't been checking it because the batteries are dead. He's not interested in a CGM. He can't really explain how he takes his insulin. He can't really tell you the units or when he does it. Okay. He's rescheduled this appointment a couple times. It's been a little tricky to get him in, but he's finally there. I don't want you to answer this, but I just want you to think about it, because we're going to come back to Joe. Realistically, what is going to be talked about at Joe's visit? Okay, if you think of all of these things, what is going to be talked about? If you're a healthcare provider, you can think of what might be talked about. If you're not, you can think about if Joe was your uncle and you went to clinic with him, what do you think would happen? Okay. Diabetes distress refers to the worries, concerns, and fears among individuals living with diabetes and the struggle to manage a chronic and progressive disease. It is absolutely clinically significant. It has a strong relationship with a person's ability to self-manage their diabetes, whether or not they take their medication as prescribed, their glycemic control, their quality of life, behaviors such as whether or not they exercise, the food choices they make is absolutely clinically significant. And they're all feed into each other, kind of like blood sugar and periodontal disease. One makes the other one worse, right? Diabetes, the more distressed you are, the more likely you are to have a high A1C. The higher your A1C, the more distressed you're likely to be. The higher your A1C, the more complex your medication. The more complex your medication, the more diabetes distress, the less likely you are to take it as prescribed. So things are all intertwined. It is not a comorbidity. It is not a complication of diabetes. It's the emotional side of living with diabetes. And it is not the same as clinical depression. So if I wreck my only good car, I'm going to be distressed, but I'm not going to be depressed. Not to say someone it might not lead to depression in a person, but they're not the same. You can be one and not the other. If I lose my job, I'm going to be distressed, but I'm not going to be depressed. I could be, but I could also not be. So I don't want to depend on a depression screening tool to pick up diabetes distress because it's not going to. That's not what it's designed to pick up. It's designed to pick up depression. And it is highly responsive to clinical attention. The DAWN-2 study, Diabetes Attitudes, just needs gag. I cannot stand that name. It's so dorky. Every time I say it, it makes me laugh. Okay, well, it's a study of more than 16,000 people in 17 countries. And in this assessment, about 45% of participants had significant diabetes distress. And about 1 in 4 said they'd ever been asked how diabetes affects their life. In a study closer to home, this was in the United States, smaller sample size, 400 people were assessed for diabetes distress, and 83% of them had elevated diabetes distress on at least one of the 7 primary sources. 64% of the patients had moderate to severe diabetes-related distress. That's a lot. That's a lot. And this is what it looks like. Intense fear of hypoglycemia, overwhelming fears of complications, frustration, powerlessness, hopelessness, frustration with healthcare team, burnout from management, frustrating results over and over, avoiding tough feelings, or even excessive blood glucose testing. All of those things we've seen, right? If you see patients, you've seen all of these things. Anyone can have diabetes distress, but it increases with any diabetes-related event. So adding on new technology, or obviously a complication, a change in medication, any change increases the risk of diabetes distress. A1C, BMI, and triglycerides are all predictors of diabetes distress, but anyone, even a person with an A1C of less than 7, can be having problems with diabetes distress. So poll question, you can read it, yell out the answer when you get to it. Just yell it out. I'll drink water while you're doing that. It's correct, D. Did everyone get a chance to read that? Yeah, what is not a component of diabetes distress, only found in individuals with high A1C. Okay, so let's go back to Joe. What do you guys think? Thinking about Joe's situation, about what diabetes distress can look like. Could Joe have diabetes distress? Mm-hmm. Absolutely. Okay, what do the standards of care say? Well, they have a lot to say, actually. If you're interested, there's a couple pages on it, but the 2 things that are in the little highlighted box, like the standards of care have, that I wanted to talk about. 1, diabetes distress should be routinely monitored using diabetes-specific validated measures. That's the 23 standards of care. If identified, diabetes distress should be acknowledged and provide specific diabetes education to address areas of diabetes self-care causing distress. So let's look at that assessment. So if you do not know, diabetesdistress.org, you can find diabetes distress assessments. They are free. They are available. We're going to go through what they look like. They're separated by type 1 and type 2 diabetes. So a person with diabetes would take the one specific to the type of diabetes they have. If a person does not have an assessment tool or it's not the right time to assess a patient, you can still use questions such as, can you tell me what bothers you most about life with diabetes? Or can you tell me something about what it's been like what it's been like for you living with diabetes recently? Okay, but looking at the assessment has two main pieces to it. It has core distress. It looks at core distress, and then it looks at source distress. You can choose to do one or the other or both, and I am choosing both, or Joe chose both, okay, because Joe has filled this out. So looking at core distress, I feel burnt out by all the attention and effort that diabetes demands of me. Joe's like, yes, and yes. It bothers me that diabetes seems to control my life. Yes. I'm frustrated even when I do everything I'm supposed to. It doesn't make a difference. Yes. No matter how hard I try, it will never be good enough. Yes, yes, yes. So Joe, 5s all the way. Joe is very, very distressed. I can print this out or I can save it as a PDF and put it in Joe's electronic health records file. So I know that Joe is very distressed, but I want to know more about why is he distressed? What specifically is distressing to him? Now, I just took a screenshot of this. There's, I think, like 30 questions, and I kind of took the screenshot at the end for what would fit on a slide. But here's some questions, how Joe filled it out. I worry about how hard it is to get to my healthcare appointment or pharmacy. Nah, Joe's got a good truck, runs fine. He's got money for gas. It's not an issue. It bothers me that I don't get as much exercise as I should. No, Joe's a busy guy. He's not worried about that at all. He's always moving. I worry about having a serious low glucose event when I'm alone. 5, absolutely. There's a story there, right? Something happened there. It upsets me that my healthcare provider seems to care more about my glucose levels than about me. Nah, not really. That's not really a big concern for him. So when I summarize all of the source, there's a couple things that stand out. Of the 7 sources of diabetes distress, there's only really 2 that are big problems for Joe. Most of them is in the normal range. But the 2 that stand out is hypoglycemia is a big fear for Joe. And the other thing that he's concerned about is long-term health. So he's got a severe fear of long-term complications. He does not feel like he would be able to prevent those or that it's inevitable for him to have complications. And those are driving his behaviors. So let's go back to Joe. What concerns or fears are driving Joe's behavior? Why is Joe not probably taking his insulin? Lows. Yeah, he's afraid of lows. And what was that? If he's high all the time, he'll never get low. But why does he not want to check his blood sugar? What do you think? He knows what? Ignorance is bliss. Sure. Mm-hmm. He knows. He knows it's high. He's had diabetes for 15 years. If he knows that taking insulin lowers your blood sugar, he knows that not taking is going to make it really high. And he has also got an intense, overwhelming fear of complications. And he knows all about that connection. So he is overwhelmed by it. So Joe does have very good reasons for why he's doing what he's doing, right? If you look at the root cause. So summary of diabetes distress, very high prevalence. And it's really expected. If a person has diabetes, it's a chronic disease, it's expected that you would have distress over the changes and the things that go on over a lifetime of diabetes. It's highly clinically significant, it should be assessed, and we are all frontline interventionists. Luckily, there's a lot of things that help reduce diabetes distress. And you guys, I wanted to talk about all the studies. I did, but I literally had to pull them out because I just didn't have time to talk about it, but I got a good summary. So these are all the things that have been shown in research to help decrease diabetes distress. Mindfulness, cognitive behavior therapy. I'm going to talk a little bit about a tool that uses some of that. Self-compassion. There's a 8-week random controlled trial where they literally just taught people to be nice to themselves, like how to not beat yourself up when something goes wrong. How do you encourage yourself with positive words instead of talking to yourself meanly, for lack of a better way to say that? They had a control group, they had a intervention group. Intervention group, they decreased depression, they decreased diabetes distress. And at the 3-month mark, their A1C was down by a whole percentage point, right? Just by being nice to themselves. Motivational interviewing, emotional regulation skills. We'll talk a little bit about that more. Problem solving skills, we're going to talk about that as well. Adding on a little problem solving skills, self-diabetes management education, big impact in decreasing diabetes distress in the most distressed people. Active listening, very cool study. They had an intensive therapeutic intervention called VMOFIT, and they compared that to a group who were just allowed to tell their diabetes story to their healthcare team and be fully listened to. They both drastically decreased diabetes distress by the exact same amount. I mean, just having people be able to feel listened to, very effective at decreasing distress. DSMES, of course, intervention using technology and group education. Lots and lots of things. But we're going to talk about 6 tools specifically that reduce diabetes distress and help a person find the expert within. The first tool we have is giving a person space to tell their diabetes distress story. So this tells you the good reason a person is making the current choices, like Joe, right? A diabetes distress story, a person tells what they're distressed about, what their feelings are about it, what does it mean to them, and how they are choosing to manage their diabetes in reaction to it. In order to elicit this conversation, you can use the assessment tool as a starting point. You rated a big concern for you that you do not feel supported with your diabetes by your family. What can you tell me about that? Or again, you can just use a question as well. What can you tell me about what it's like? What bothers you most about living with diabetes? The kind of things you might hear about: lows that are scary, highs that feel inevitable, embarrassment, judgment, difficulties with medical appointments. All of these things are things that you might hear about. Then you want to narrow down the problem to the most pressing issue for today. So for Joe, who rates that he's very afraid of having a low blood sugar by himself, we might want to say, was there a particular situation that triggered some of these feelings? We want to know what the root cause is behind it. Okay, which leads us to our second tool, which is problem solving. If you guys know me very well, you have heard, I love this tool so much. I've used it forever and ever and ever. I didn't invent it. It's been around forever. And I use it even in my life. It's a very simple tool where it just helps you break down a problem in a very logical way. And raise your hand if you've seen this tool before. The 4 questions. Yeah. Okay. Yeah. Some people have seen this before. Okay. Break down the problem in a very logical way and get out of this kind of spinning cycle we can all be in. Okay. So I got a story for you. Typically, problem solving, we would want to do it first person, right? We're not ever trying to solve problems for other people. That's obnoxious and irritating. But for the sake of this group, I will read you about a diabetes distress story, and we'll problem solve some of it together. Okay. So this is the story Annie told me. Most of Annie's friends are from her church. Her church has lots of community functions. Most of these functions have potlucks. Annie's church friends know that she has diabetes, and they make comments on anything she picks to eat at the potluck. Healthy or not, big portion or small, she feels constantly judged, and it's embarrassing. She's had it. She's even stopped making up excuses for why she couldn't go to these potlucks. Diabetes is ruining her life. Okay. So the first thing that we want to do is break down just the problem. We're going to do just one step at a time. And I'm going to do the first one because it kind of can get tricky for people. But the problem, we're only looking at the problem, is when Annie goes to her community church functions, everybody feels comfortable making comments on anything she puts on her plate. They feel very comfortable commenting on her food choices. Problem defined. Step 2, how is it affecting Annie? Negatively. Yeah. What did Annie say? How does she feel about it? It's ruining her life. It's embarrassing. Bad. Sad. Yeah. She stopped going even. Okay. Third question. And we're not solving it. We've defined the problem. We said how it's affecting her. Why is this happening? Her friends feel comfortable with the care. She's not correcting them. She's not setting boundaries. Yes, correct. Okay. So this is where a lot of times we get stuck, these first 3 steps. And when I say we, I mean like the world, right? Think of how many times we've done this. Like, they're making me so mad. They only do that to me. It's BS. I want to talk to someone else like that. Do you know what they said? I mean, we kind of like go and spin around in those 3 things, but we never really get out of that, or never. I mean, often don't get out of that to take that last step. Well, what are we going to do about it? Okay. So people feel comfortable making these comments. It's embarrassing and judgmental. It's stopping her from going. It's happening because she hasn't really communicated her needs. She hasn't set boundaries. They feel comfortable. What can Annie do about it? Let's take the last step, which is work towards solving it. What can Annie do about it? She could make new friends. Yeah. Talk to her friends. Yeah, communicate her needs. So obviously I picked a story for the sake of time. It's pretty easy to solve. Some things like Joe's hypoglycemia might have several answers. There might be several things to choose from in the problem list, but we're going to make this one pretty easy. And that is, yeah, she's going to have to talk to her friends, which leads us to tool number 3, because a lot of our problems involve other people. Am I right? If I didn't have to mess with it, I'd have a whole lot less problems if I didn't have to interact with anybody else, right? So problem number 3, tool number 3 is called DEAR, and it's about asserting yourself. Asserting yourself, communicating your needs decreases diabetes distress. It also helps prevent diabetes distress. Okay, so when we think of assertiveness, it kind of bugs me because assertiveness is often used as a synonym for what? Yes, and it's not. Assertive is not aggressive. So aggressive is, I care about my needs, but I'm not really so worried about your needs. Passive is like, oh, your needs are very important. My needs don't matter. But assertive is like, I care about your needs and I care about my needs. It's really the only fair way. So DEAR is a tool to communicate your needs, to be assertive. D, describe the problem, and folks can write it out and practice it. Describe the problem. E, express how the problem makes you feel. A, ask for a change. And R, reinforce how the solution works for both of you. So Annie might say something like, maybe she's, talked about meeting with folks one-on-one or in a group. We're going to say a group because it's easier for me. So she's like, D, hey guys, I really like coming to the potlucks, but every time I come, people make comments on anything I put on my plate just because I have diabetes. E, it's makes me uncomfortable. It feels embarrassing, and it makes me not want to come anymore. I've been making up excuses to not come. A, I would really love it if we could just, enjoy each other's company, be friends, have a good time. But if no one would make comments on my food choices and just trust me that I'm the person with diabetes and I can handle the choices I make. R, I think that'll be better for all of us because then we can focus on the things that we all like. You don't have to worry about me. I don't have to worry about being judged. We can go back to having fun and enjoying the potlucks, right? Okay, tool number 4, reframing negative thoughts. So this has some cognitive behavior therapy, which cognitive behavior therapy is kind of based on, to make it simple, our thoughts affect our behavior, right? The way we think about ourselves, the way we talk to ourselves ultimately affects our behavior. So let's say I'm a sedentary gal and I want to start exercising. So I hype myself up and I walk to the post office. It's about a quarter mile away. And it was hard. So I say to myself, I'm so out of shape. I can barely even walk to the post office. How does my body feel? What'd you say? It hurts. How do I feel when I talk to myself like that? How do you feel when you talk to yourself like that? Yeah, negative self-talk. Yeah. Defeated. Reinforce the negative, reinforce the being out of shape part. Not rewarding yourself. Yeah. Okay. So the 3 C's is a tool where we catch it, check it, and change it. If we're a person who's very used to using negative self-talk, beating ourselves up, it's actually hard to identify sometimes when we're doing it. So we think about, okay, I just said something and like my body doesn't feel good. Like I feel tired. I feel sad. I don't feel good. So how I just talked to myself probably wasn't good. So I'm going to check it. And there's different ways to check it. You might say, is this based on fact, depending on what you said yourself. In this situation, I might say, I'm going to check it. Is this something I would say to a friend in the same exact scenario as me? Would I ever say this to my friend? And if the answer is no, then I would know it's probably not a kind way to talk to myself. So I'm going to change it. How would I say this to someone else? Because at bare minimum, I want to at least treat myself like I would treat someone else. And then I'm going to change it. I'm proud of myself for taking the first step to get in shape. Each week I will see progress. Now, how is my body going to feel after I say something like that to myself? Right? Like puffed up. Yeah, puffed up. Good, right? So there is lots of evidence on this kind of thing that we can retrain ourselves to think more positively, to be kinder to ourselves, to change the way we talk to ourselves, and it will have a change on our behaviors as well. And it's shown to decrease diabetes distress. As you might remember, the kindness one, people decrease their A1C by 1% after an 8-week program. Tool number 5, address inaccurate beliefs. If you remember Joe, that one of the things that was very high was he felt like he was doomed to get complications. And this is not uncommon. Some of it's healthcare's fault, right? People have been threatened with complications for so long, everyone thinks it's inevitable. So this tool, we want to reflect back using their own words. It sounds like you believe you are doomed to get an amputation. Many people with diabetes believe that they're doomed to get amputations. Is it okay if I share some information you might not have seen before? Because we have lots of data that shows lots and lots of people don't get amputations. It's not common at all. People used to get complications far more frequently, but lots of things have changed the way we treat diabetes, right? Amputations are not common. And here's some data, Alaska Native specific data. And Mir, I'm going to butcher the data. Mir just gave this to me. I wrote it down on a piece of paper, but I lost the paper. But it's something like 560 people diagnosed between the years of 1988 and 1997-ish, give or take. How'd I do? Okay, it's not perfect, but it's something like that. So they've had diabetes for over 20 years. And you can see the risk of amputation, for example, is quite low. Some diabetes distress requires problem-solving teamwork. So things like very high blood sugars, very low blood sugars. And another tool we want to use is looking at the toolkit, organizing the toolkit and collecting the information. So making sure everybody has all the supplies they need, nothing's expired, they know how to use them. If we think about our friend Joe, would having glucagon help him? Does he have it? Does he have a carbohydrate source? You want to taste them, test them, check blood sugar before and after so he feels comfortable. Does he have a plan on how to respond to low blood sugar? Have we talked about CGMs not as a tool for measuring blood sugar, but as a tool that has alarms that can alert you if you're sleeping for low blood sugar, something that will help him feel safe and secure? So looking at all the tools that we have to help with the diabetes distress situation as well. So let's go back to Joe. What if we don't ever acknowledge diabetes distress? What if we don't ever assess it? We don't hear his diabetes distress story. Realistically, what happens at his visit? Yes. 100%, right? 100%. It's review that insulin plan once again. Here's how you do it. Here's how you take it. Look how high your A1C is. You can get complications. All of the fears that he has, all of the distress just gets reinforced. Come back in 3 months and let's see if your A1C is down. What? He's beating himself up for coming. Yeah, exactly. So if we don't acknowledge diabetes distress, we just make every problem worse. All of his fears worse. But let's think of the tools we just talked about. Which ones might help Joe? And I'm not saying we do them all in one visit, but which ones might help him? Tool number 1, telling his diabetes distress story. 100%. Just telling the diabetes distress story, being heard by your healthcare team, decreases diabetes distress. It's also super helpful for those of us on the healthcare team, right? How about problem solving? Yeah, absolutely. So again, we did third person problem solving, but we would work through and he would be solving his own problems. So his step 4, his problem solving might be, I'll take 1/4 or 1/2 of the prescribed insulin. I'm not taking it all, but I'll take a little bit of it. That's my first step that I would take, right? It might look totally different if he's solving his own problem, which would be a great first step. Dear, assertiveness, maybe not. Reframe negative thoughts. Yeah, so on his assessment, he said he felt like a failure. So he used some of those kinds of words where, not helpful. Address inaccurate beliefs. Absolutely, right? Because the thing he rated all the way to the end of the distress scale, complications were inevitable. There was no way he was not going to get those. So we want to address inaccurate beliefs. And finally, organizing the toolkit and collecting information based off what we know about his distress. Yeah, absolutely. So thinking about the visit, if we do acknowledge his diabetes distress, that visit could look a lot differently. Okay. Diabetes distress is highly malleable. It's highly responsive to intervention. Dramatic reductions can occur quickly, and interventions do not have to be time-consuming or require extensive mental health training. Not to say that there are not situations that warrant a referral to a mental health provider. There's lots of them. Eating disorders, obviously, if someone tests or is assessed positive for depression or anxiety or declining or impaired ability to perform diabetes self-care behaviors. So conclusion, I went through this so fast. I practiced this and I could barely get it done in an hour. So I don't know. I must have talked fast. All right, thanks. Conclusion, there's a very high prevalence of diabetes distress, no question. It is clinically significant and interferes with the person's ability to respond to education or interventions. The tools to assess diabetes distress have been developed and they are available at diabetesdistress.org. The standards of care advocate for routine assessment of diabetes distress. We know there are lots of tools that work. The challenge is to make assessing and addressing diabetes distress routine care for all people with diabetes. Thank you. I really can't believe I cut so much out, like 10 o'clock at night. I was cutting stuff out. Well, whatever. Okay. Anyone have any questions? Yeah. The distress scale on an iPad, on a
laptop? Do you give them a paper form? How do you find the time to have them answer the 30 questions? It's a great tool, but it's a little lengthy.
Yeah, it is. Okay, so first, I just learned about the tool. So I have not actually even used the tool. I just took a workshop. Do you guys know Beverly Tomasian? She was here. She spoke here before. She's excellent. So she has a Revive 5. It's called Diabetes Distress. I think it's like a 15 credit course, which I just took. And that is where I learned about the assessment tool. So I have not used the assessment tool. Now there are 2 versions. And I don't know if I made this clear or not. There was the core one, which was like 5 or 6 questions. So you can use just one piece, or you can use the source as well. I don't think it'd be that useful without the source personally, because I'd want to know where the distress is coming from. So I think, I don't know, at ANTHC, our diabetes educator appointments are pretty long. There would be time to fill out an assessment. So I think some of it might depend on how much time you get with the person. Does Chris want to answer?
So
that?
I actually did a diabetes distress certification a little over a year ago. And looked into this and worked with IT to try to get these put on our iPads that move around in our clinic, which we do our Zoom meetings on. And after 6 months of it bouncing back and forth between lots of places, they ultimately came back and said, these iPads are locked down. We cannot add this link on. But originally our thought was we pull up the Zoom link, we have the patients do it. You can't really have them do it on paper form because when you do the electronic form, it gives you a score, like it automatically goes through and scores it. I will say I kind of had those questions after going through, looking at it several times, playing with it, that I can walk into a room and I actually have some of those main core questions in my head. And then I can kind of narrow the patient down to specifically what's causing them to not take their meds. So when I get somebody who comes in, we get these referrals from primary care. Patient's not taking their meds. Okay, what do you want me to do? I'm not going to go home with them and make them take their meds. So really, what do you want me to do? Well, I'm going to tell you the difference. When they come to us, we sit down. We probably take a little more time than primary care. Plus, we have educators that come in after us to really drill down what's causing the issue to not take their meds. Is it a side effect? Is it you're scared of it? I have one lady who absolutely refuses all injections because her mother died. Maybe because she got the wrong insulin, but she was already on death's door. So did that really make an effort? And so we're really struggling with her on that. And so really drilling down, well, maybe we need to really change this medication regimen instead of these repeated primary care notes that make it sound like they're yelling at them and threatening negatives, the complications. And I won't even focus on complications. I focus on what have you done? Your A1C is down 0.2 of a point and you're down 0.5 pound. You know what? I'm going to be your cheerleader because of this tiny little step you've made. So I really focus on it as being a cheerleader and a champion for my patients and trying to help them figure out the problem solving that they can take home. And even if it's 0.5 step forward and a 1/4 step backwards, just really try to champion on.
Yeah, thank you. So you can, the paper, like Christy said, you have to score it yourself. There is information on the website of how you can score it yourself if you want to print it out. But really, even if you got the answers from it, you could look and kind of identify some of the sources. Or like Christy said, you can ask questions, pointed questions as well. Yeah, great. Yeah, thanks. Yeah.
I just wanted to say thank you. It was a great talk. And I wanted to follow up a little bit. As a primary care provider, I find one of the things most successful in these conversations is just strength-based, as we're talking about, and saying, what are the barriers to you feeling better? And then also like really walking the talk. How often are we talking about burnout or our own stress responses? And if anyone hasn't read the book Burnout by Emily Nagoski, I don't know if you've read it, but it's a fantastic book about how we all can complete our stress cycle in a day by progressive muscle relaxation, breathing, moving our bodies, having meaning. And I find those conversations where I talk about what I'm trying to do to manage my stress and burnout as a provider usually really helps bring that to a really normalized place for our patients. Because everybody experiences stress. And if we don't talk about those social determinants, we're never going to get the A1C better. And last year's talk at the conference did a great job of talking about it as well. So I just really want to thank you and encourage anybody who isn't reading and thinking about burnout in yourself. It affects how we show up in the room with our patients. So we can't tell people to do things if we're not doing it ourselves.
Yeah, absolutely. Yeah, great comment. Thank you. Yeah, Kim. Mm-hmm. Like what is that breathing pattern? Okay. Oh, it does. Absolutely. So I will tell you, my oldest boy has problems with anxiety. So I have a personal interest. Like I got the books. If like even to every time I saw these like the studies, I'd be like, oh, that name looks familiar. Oh, I got that book on my shelf. Right. Like I am interested in this because it is important to teach tools to people, and the tools work. It's amazing. They work. And so our whole family does these because we're helping my oldest son. And then just some of the skills he has. He's now 16. I mean, he still uses them, but he'll say things like, there's a lot of change coming up. I'm feeling really anxious. So I just need to remember to be patient with myself and kind to myself because, he know, and I'm just like, dude, do you know how many adults can't reflect on the way they feel? They can't anticipate change, knowing that is going to be difficult. They can't give themselves a break. Like, it is amazing. The tools are very powerful. So I'm actually passionate about all these tools. But it started with, when my kid was in the 4th grade, like I said, he's 16 now, but yeah, but they work.
So I really wanted to thank you as well. This was a great chat. The one thing that I wrote down, and there's a lot of literature out there, if you haven't heard the word power differential in the medical setting, especially if you're working with Indigenous population, that you as a medical provider, a nurse, whatever, someone comes in that door, you are up here and they're down here. They're like, okay, I'm at your disposal of what medicines you're going to give me, whatever you're going to do. To let them tell their story helps to balance out that power differential. It helps bring a partnership together with it. So it's really I'm glad you talked about that, because that's really a great way to hear their story. And you may find out things. I have found things out about patients that, oh my goodness, I'm so sorry that happened to you. Let's make sure that doesn't happen to you here, or what their fears are, or what their different things are. So yeah, thank you. So just keep that in mind as providers. We are often seen up here, and patients, they can be very fearful to say what they really think.
Yeah. Thank you. Yeah. Great comment. Yeah.
I think it's important that we remember the underlying emotions that the stress response elicits. That it's really like fear and anger.
Mm-hmm.
Be able to find that person that is balanced, so it's not to switch that situation at all.
Mm-hmm.
And otherwise, that stress response still like at that minor level that's still affecting us. I think that's the power of biofeedback, because you actually have to move on when you can see the response, like even the thought, something negative, start to listen to that stress response.
Yeah. It's wild.
It's so sensitive on the system.
Yeah. Yeah. Thank you. Yeah. Joe, did you have a hand up? No. All right. So peripheral vision. It's peripheral. Sorry. Anybody else? All right. Well, thank you guys so much for coming here. I appreciate it.